Thank you very much for being here. We're honored by your presence.
Thank you so much, Dean. It is amazing to be back at Tulane. So thank you so much for that that introduction and the tremendously warm welcome, Dean. So as you pointed out, I was fortunate enough to come to medical school here, and this is my 40th year graduation, my 40th year reunion. So I graduated in 1983. I think that there are some members of our class here, so it is great to see you. Dean, I received an excellent medical education at Tulane. My basic science training, my clinical training have served me extremely well in academic medicine and in public health. And I want to tell a story. So I like to tell stories. I don't know how many of you know this story. So obviously we were at graduation, which was uptown. And I went to lunch with my parents and my ex-wife's parents, Martha Levine, who also graduated from Tulane in '84. And so all of us were at the Pontchartrain Hotel. So you all know the Pontchartrain Hotel. And we had this absolutely wonderful lunch there right after graduation. And we walk out of the Pontchartrain Hotel, and there's a woman seizing on the street in front of the Pontchartrain Hotel. And she's having tonic-clonic seizures. The staff were trying to put her in a chair, which was going to be less successful than it might have been, given that she was having tonic-clonic seizures. And we said, you know, you need to call for an ambulance. And so great. So they called for an ambulance. It was a little slow. It took 45 minutes for the ambulance to come to see that woman. So during that time, she woke up. She did tell us that she had a history of seizures. She had been on Dilantin. She lost her medicine. And then she was seizing, and then she went into status epilepticus, and she was just seizing. So the ambulance comes, and I walk up. And, of course, at that time, my name was Rich Levine. And I said, hello, I'm Rich Levine. This is a 45-year-old woman with a history of tonic-clonic seizures. She's usually on Dilantin. She lost her medicine. Her level is low. She's been seizing now for a period of time, and now she's in status epilepticus. And they went, who are you? And I went, well, I'm Rich Levine. In fact, I just graduated from Tulane Medical School. In fact, actually, here's the diploma. Literally in my hand. So they call up the little box. I don't know if you remember at that time, they had a little box that they would ramp up and then call the ER. And they said, oh, we have this woman, she's really ill. She's in status epilepticus, but don't worry, we're with MD. And I went, you're with MD as of 2 hours ago. So no pressure now. So they placed her in the ambulance. Actually, we got into the ambulance to attend to her and waved bye to all of our proud parents, you know, who just waved us off as we went off to Charity Hospital. And so about 2 hours after I graduated, we rolled back into Charity Hospital. Now, during the ambulance ride, she became apneic, so we had to get out the ambu bag. And so 2 hours after my medical school graduation at Tulane, we will roll back into Charity Hospital, bagging this woman with seizures. And she did well. But it was like a little bit of pressure. So for any medical students here, don't worry about it. So, you know, it's keep calm and carry on. So at the time I graduated from Tulane, I absolutely never thought that I would be in this position as the Assistant Secretary for Health and a 4-star admiral in the United States Public Health Service Commission Corps. So every experience, whether big or small, adds valuable life lessons. You know, many of us get frustrated with our medical and public health systems, sometimes a little bit, sometimes a lot. But really, it's important for all of us in all of the different fields we might be in to remember how much our work improves people's lives and saves lives every day. I have always felt so gratified by my career in medicine and now in public health because all we do is help people. We might help people clinically, we might do an education, or we might do it through research and through public health, but all we do is help people. So what could be a more gratifying career than that? I wake up every day with the mission of helping people, and this role lets me help people really with a broader public health brush across the nation by setting policy and working, as the Dean mentioned, the United States Public Health Service Commission Corps. We are America's health responders. Public health officers are first in line to defend our nation against public health threats large and small. We have medical professionals, nursing professionals, other healthcare professionals. We have engineers and environmental health officers, and they fight disease, conduct research, care for patients in underserved communities. We have 1,000 officers in the Indian Health Service. We have almost 1,000 officers in the Federal Bureau of Prisons taking care of patients. And we work across the nation and across the world. So just kind of remember us. We're a little bit unknown about the Public Health Service, but really our officers are fantastic. And one of the most gratifying aspects of taking this position is the opportunity to have my commission and to take the uniform of the United States Public Health Service. So I'm excited to share some of the work that we're doing at OASH. Everything in the federal government has acronyms, and that is the Office of the Assistant Secretary for Health. Our vision is healthy people, healthy communities, and a healthy nation for all. And the for all is very important because it really we have to emphasize health equity in everything that we do. We are leading key policy initiatives. We work across the government as the convener and expert consultant, particularly about health equity. The Secretary of Health has called us the connective tissue of the department. When I heard that, I mean, I have to tell you, I was hoping for the beating heart of the department, but I got connective tissue, so that's okay. We work to protect and secure access for reproductive health care, advance LGBTQI+ equality, address climate change and health equity, and prevent, detect, and treat long COVID. The long COVID efforts are coordinated through our office, among other goals and priorities. So when we get to the Q&A, I am pleased to answer questions about anything in our portfolio or anything you want to ask. But right now, what I'm going to spend my time on is talking about the impact of climate change on health, and particularly the impact of climate change on health equity. Health crises don't wait their turn. They descend at the same place on the same people at the same time. We have certainly seen the challenges that our country have faced with the COVID-19 pandemic. And as we work through the pandemic and the public health emergency ends in May, of course, we're also left with long COVID that we need to address and try to prevent and then understand and to treat. But we also have seen how extreme weather, stoked and exacerbated by climate change, has added to the health threats of COVID-19. It has shut down testing and vaccination sites. It has forced people to balance sheltering and the risk of COVID-19. It has threatened healthcare facilities already stressed by the surge in COVID-19 cases. So we need to address this now before the next disaster strikes. Climate change, has been called an existential threat, which somehow implies that it's a threat for the future, that it's a threat in 2040, 2050. Actually, climate change is a threat right now, and the situation is very challenging. Extreme weather has increased. It is expected to worsen. We're seeing increased heat waves, which affect people throughout our country, as well as throughout the world. Fires in the United States, but fires also throughout the world, the smoke from those fires. Worsening hurricanes and storms. Rain becoming at times more frequent or less frequent, but more intense, and droughts that are clearly more frequent and severe throughout the world. So people tend to think of these natural disasters as sort of impacting the earth, but actually they impact people, and they impact people's health. And there is a human toll, which includes everything from cardiovascular disease to cancer to mental health and even mortality. New Orleans is no stranger to the impacts of extreme weather, from heat to hurricanes and more. So it is vital that we all work together to build resiliency into the healthcare system and our hospitals, as well as work to reduce the carbon emissions in the health sector. In the United States, the health sector accounts for 8.5% of carbon emissions. 8.5%. It is very significant. I was recently in Miami, where they have a children's hospital that they've built that's able to withstand a Category 4 storm. They are building for resiliency throughout the country, and it's very important. It's important here in New Orleans. So we need to create a community of collaboration where we share opportunities, challenges, and lessons learned, and we are working to do that at the United States Department of Health and Human Services. Health needs to be central when we talk about climate change. So we are at the table now. On the National Climate Task Force, the Secretary of Health has a seat. I'm honored to take that seat when he's away. As we listen to all the different things that are going on throughout the administration about climate change, health is right there talking about the challenges that we're facing. But also, it is the same communities that have faced health disparities from COVID-19, from nutritional insecurity, and more, that are facing the biggest challenges in terms of climate change. Far too many disadvantaged and low-income communities, far too communities of color, continue to bear the brunt of these challenges of climate change, as well as the challenges from environmental justice. Pollution from industrial development, agricultural practices, cumulative impacts of land use decisions, transportation, and trade corridors. I have traveled across the country meeting with communities facing these significant health burdens. And it's been really challenging. It disturbs me. I have had conversations from New York to Florida, to New York to Seattle, where we've been talking about extreme heat leading to death in Seattle, Washington. Farm workers and immigrant advocates in Orlando told me they're not just worried about the environmental challenges, the environmental justice challenges, and the pollution, but they're worried about working longer hours in the sun. And they worry about what longer summers mean for longer planting seasons, more exposure to health stresses, more exposure to extreme heat, more exposure to pesticide. The farm workers in Orlando say, and this is well known, that they leave their kidneys in the field. They leave their kidneys in the fields because of the effect of dehydration, chronic dehydration, sustained dehydration on their kidneys. They leave their kidneys in the field. I was recently in Durham, North Carolina, where I heard about communities inundated with coal ash, industrial chemicals, farming waste, and other pollutants. So in addition to climate change, we have other environmental justice challenges. And we have a sister office to our Office of Climate Change and Health Equity, which is an Office of Environmental Justice. Actually, tomorrow, I'm going to be traveling to, quote unquote, Cancer Alley outside New Orleans to see the impacts of the community firsthand. Cancer Alley, of course, refers to the 80-plus mile stretch of the Mississippi River between Baton Rouge and New Orleans, where approximately 200 industrial and petrochemical plants are located across the river and near the river parishes. Communities live in the shadow of these plants. They struggle with air quality issues because of emissions from factories and industrial complexes, and they grapple with increased cancer rates because of these exposures. Now, as more than 200 medical journals wrote in late 2021, climate change is already the top threat to public health. It's climate change, the impacts of climate change on health, which is the top threat to global public health. It impacts us at many levels, physically and mentally, and is particularly damaging to those vulnerable communities. So we have set up these two new offices, our Office of Climate Change and Health Equity, the acronym is OCHE, and an Office of Environmental Justice, OEJ. Both report to me. The missions are to coordinate the action of every agency at HHS and really across the administration in supporting environmental and health needs of communities and facilities across the country. We're doing work to raise awareness about these risks and these threats, and we're introducing resources and supports to help communities and healthcare providers accelerate their work on preparedness and on mitigation for these challenges. So we have invited the private sector in the health industry, hospitals, health systems, but more, pharmaceutical companies, really those in the supply chain, all companies involved with the health sector, to take a pledge on resilience and decarbonization. It is the White House HHS Healthcare Sector Climate Pledge. To date, more than 100 organizations representing over 1,000 hospitals, federal and private sector, have made those commitments, including 15% of U.S. hospitals. They include suppliers, pharmaceutical companies, insurers, other healthcare stakeholders. And we introduced a steady stream of funding and technical assistance to them to be able to accomplish their mission. And we reopened the pledge this month. And we'll be reporting on who has joined on Earth Day later this spring, and then we're reporting again in November. The voluntary pledge asks them to, at a minimum, commit to reducing their organization's emissions by 50% by 2030 and to get to net zero by 2050, and to publicly report on their progress towards these goals, as well as completing an inventory of their supply chain and develop climate resilience plans for their facilities and their communities. Now, Congress last summer passed the Inflation Reduction Act, and this makes investments in more resilient and energy efficient infrastructure, including in the healthcare sector. We reinforce this effort through the National Academy of Medicine's Climate Collaborative, which I co-chair. And so we're working through the National Academy of Medicine to influence organizations to accomplish these goals, whether they take the pledge or they don't take the pledge, and also providing education and technical assistance. All across the country, we're seeing major threats to communities and health systems associated with climate change. A recent study showed that more than a quarter of health systems are not able to withstand a Category 2 storm, and you know better than anybody what storms are like. Now, in addition, as I mentioned, we have our Office of Environmental Justice. This office is leading initiatives that integrate environmental justice into our mission to improve health in disadvantaged communities and vulnerable populations, develop a strategy to do that, coordinate different reports, provide the Office of Civil Rights with environmental justice expertise, and provide training opportunities. The President's budget released just last week provided funding for both of these offices to do their work, and we're working every day to do that. So this is a very challenging time for all of us as we work through the COVID-19 pandemic and the end of the public health emergency, but we also have to address the issues of long COVID and so many challenges. But it is essential that we also work to address the health challenges associated with climate change and environmental justice writ large. These harm to our communities and disruptions to healthcare are happening right now. And so history will judge us for the actions that we take or the inaction that we take. And I choose to take action, and hopefully all of you will too. So in conclusion, despite the heavy toll that it has exacted, the COVID-19 pandemic has also reminded us of a fundamental truth, that we truly need each other, that our happiness and our very survival depend upon our connections to one another and to our community. And that spirit of community is truly what makes our country great. And it's what we need now more than ever. We know that there are many groups that have faced unique and increased risks. We must close disparities in access and outcomes, eliminate bias and discrimination, and address the systemic barriers, including the barrier of systemic racism, that have contributed to historic inequities. All Americans deserve care and services that are timely and affordable, accessible, equitable, and high quality. These are our family members, our friends, our neighbors, our students, and our coworkers. As a nation, we can do better. We must do better, and we will do better. So thank you so much for inviting me today. Wonderful to see all my classmates. And with the Dean, I'm pleased to answer any questions. Thank you.
So that I don't forget.
Oh, thank you so much.
Small gift.
That's wonderful. Thank you.
I would forget otherwise, but we're gonna do
Well,
some.
my staff will make sure I don't forget to.
I have James's laptop over there, I think. Anyway, let's not forget that. But anyway, thank you for that wonderful address. You know, you touched on a lot of things, and one of the things that I think, you know, as individuals, as part of an institution, what can we be doing, either individually or as an institution like Tulane, to help in this dealing with climate change?
So I think it is important that Tulane work on this issue and other institutions work on this issue with all of your missions. We were discussing all of the academic missions. First, in terms of education, we strongly feel that these health impacts of climate change and environmental issues should be part of a medical student's education, should be part of a nurse's education and other medical professionals, that it is going to be more and more important for physicians and nurses and other medical professionals to understand these challenges, to be prepared, for example, for extreme heat in Seattle. I know you're prepared for extreme heat in New Orleans. I remember that very well, but they're not in Seattle and they're not in many other parts of the country or parts of the world. So to teach the medical students and the residents about these issues. I think it is also important for institutions, academic medical institutions, but other healthcare to look, whether they take the pledge or not, although I think the pledge is great, to look at resiliency, right? We have seen clearly how storms can impact the health systems and the hospitals in New Orleans, right? More than almost any other place. And so we have to build resiliency into the healthcare sector against the storms that are exacerbated by climate change. Now, New Orleans has seen storms forever, but these storms are more frequent and they're bigger and worse because they're stoked by climate change. And that's just going to get worse right now. And so the hospitals and health systems have to be prepared in terms of your public health preparedness, but also the buildings have to be resilient. And then to look at decarbonization, to look at your carbon footprint. I mean, think of in a hospital or a health system of all of the things that we do. I mean, some of it even is looking at the gases that are used by anesthesia, but also looking at the supply chain. So we are asking hospitals literally to, in terms of the ordering of IV bags or whatever you order, to, this company is looking at decarbonization and their carbon footprint. That company isn't. You pick the first company, and you look towards decarbonizing not the plant, and you look towards in everything that you're doing. Because I think, again, the healthcare sector is 8.5% of carbon emissions. So if we're going to achieve the president's goals of cutting them in half by 2030 and carbon neutral by 2050, the health sector has to be at the table in terms of these issues. And I think it is important for every physician, for every nurse, for every healthcare professional to be aware of this at your institutions. So we have pledged to do that in the biggest health system in the country, and that's the VA. So the VA is looking at that. The Defense Health Agency is looking at that. At HHS, the Indian Health Service facilities, the HRSA, FQHCs, and more. So we are at the table, and we want the private sector to be at the table as well.
Thank you. You touched on this about the vulnerable populations, those most underserved, are frequently the most affected by climate change, by the negative health effects. So I'd sort of pose the first question back toward that. What can we be doing for underserved communities that is particularly relevant to climate change and the health
Absolutely.
effects?
So if you think about underserved communities throughout the entire United States and the world, but we're going to concentrate on the United States. So let's think of the Black African American community, the Latino community, the American Indian Native Alaskan community, and other underserved communities. They are feeling these impacts worse, right? So we saw that in New Orleans. Right, in terms of hurricanes and wards that still aren't rebuilt. We have seen that if you're in Seattle and there's a heat wave and the temperature is 105 for a week, if you have means, you'll have air conditioning. If you don't have means, or especially if you're a senior and you don't have means, then you are absolutely at risk. So communities, and I think hospitals have to also, hospitals and health systems pay attention to what's going on in the community, have to work to equalize that. extreme heat on American Indian reservations. The impact of climate change is being seen probably most acutely in the Arctic. And so that addresses the Alaska Native communities. The Latino communities I mentioned in Orlando, in the field workers, and also across the Southwest and in California. So I think that it is incumbent to take this health equity lens about this issue and every other issue, and to concentrate on mitigating the health impacts in those communities.
Thank you. You mentioned a couple of, I think they're new offices that help address these. One of them was the Office of Climate Change and Health Equity.
Right.
And the other, the Office of Environmental Justice. If you could maybe expound on those just a little
Sure.
bit, what those are doing.
Sure. So they're both two new offices. They are sister offices, so they're kind of linked in the same division, so to speak. I want to point out that the funding for all those offices has been in the 22 budget and the 23 budget. But they are currently unfunded offices. We have funding for them in the 24 budget and hope springs eternal, but we can imagine the challenges that we might face in the 24 budget. So we are literally cobbling together money because Congress has not seen fit to fund those offices, primarily because of political purposes. And so so we're doing what we can with there's not as much resources. So in terms of the White House pledge, our Office of Climate Change and Health Equity is leading that. So we are leading, talking with hospitals and health systems, trying to provide technical assistance and education. We're coming up with a pathfinder to the Inflation Reduction Act, so that hospitals and health systems and others in the healthcare field can find money to be able to accomplish that in the Inflation Reduction Act. And so we're working on all of that. They network with the National Academy of Medicine, and they are providing webinars and technical assistance to hospitals and health systems. Our newest office is our Office of Environmental Justice. And so, I mean, we don't have an environmental justice SWAT team right now. I mean, what we're doing is to look at this from a policy perspective. And so our team goes out to different areas that are very challenged. I go out to areas that are challenged. So for example, I was in Los Angeles. There is a school in Los Angeles that has been there for many, many years next to a metal recycling plant. That school and the grounds of that school have been contaminated with heavy metals and sometimes even shrapnel from that plant. And we're really worried about the lead contamination and heavy metal contamination of the soil in that school. So that is something that we have looked at with Representative Barragan from that area, and now the Los Angeles Health Department and the other departments, environmental protection departments, are looking at that. Same thing in terms of seeing the farm workers in Orlando. So we came and spoke with representatives from the farm workers about the challenges that we're facing. We went with Representative Richie Torres in the Bronx. The Bronx suffers tremendous challenges because all those highways that go to Manhattan, and all those highways that bring all the trucks that bring supplies to Manhattan go right through the Bronx. And those are elevated highways, and all of the pollution that comes from those trucks and those cars all settles down in the communities there. And so they have tremendous air pollution, the highest rates, some of the highest rates of asthma in the country. So we have a way to look at that. It's called an Environmental Justice Index, EJI. And so you can see it on the CDC website. And so you can look by census tract at where you live or any of these communities and see the environmental challenges at those communities. And so, you know, if they're if they're in the lighter colors, they're doing pretty well. And if they're purple, like they are in Cancer Alley, right, you can see the line of purple, then those have significant environmental justice challenges and climate change challenges. And this is a longitudinal cumulative impact report. So you can go Google it. It's the Environmental Justice Index. So that's what the offices are doing, even without any money.
Well, one of my prepared things said, "Aren't we ground zero?"
New Orleans and Southern Louisiana is ground zero for these environmental challenges. Right. I'm in the right place.
You know, I think we all know that we have a richness of things that we need to address. Maybe some comments in this regard about this intersection of climate, health equity, about mental health?
Yes. So, you don't tend to think of mental health about these issues, but there are significant mental health tolls taken on communities that live in these areas. So let's look at another EJ issue, PFAS compounds, the forever chemicals. And so I went to Tucson, and in South Tucson, it's very near what used to be, I believe, an Air Force base. There's tremendous amount of PFAS compounds because they were used as they practiced to put out fires at airports. So wherever there are airports, you're going to find PFAS compounds, but one of the highest areas in this area of South Tucson. And so they have a water treatment plant that has been looking at many different things over the course of the last 30, 40 years. But now they didn't know, but they have this enormous plume in the aquifer of PFAS compounds. So we're looking there and trying to work on helping that community deal with that, getting them water, working with their representatives and with Arizona to try to deal with that plume. Well, those areas are throughout the country. And so the Office of Environmental Justice, with no funding, is working to really outline those areas and develop policy, make connections and develop policy issues for that. And so that's how the climate change issues, the environmental justice issues, and the health equity issues all kind of come together.
Having both a medical school and a school of public health here at Tulane helps us approach this from, both a medical and a public health angle. How do you suggest that that we change training to address these?
Well, I think we have seen through the challenges that I've been talking about, particularly right now, though, with COVID-19, the critical importance of public health. Public health right now is the center of the universe. I used to think it was Brooklyn, but actually it's public health. And so we really have to, and we can see how challenging COVID-19 has been to our local communities, to our states, to our country, and actually to the world. And I think that we need to educate our medical students and nursing students and others, but right now talking about medical students, more about the basics of public health, because I think that the more that physicians know about public health, even though they're not public health professionals, even though they're not in public health, the better they would have been able to deal with COVID-19 and understand the recommendations that are coming from the federal government or the state government, and then better able to implement them. So I think it is really incumbent for all medical students to have a basic grounding in public health and epidemiology. I know that this is an enormous challenge because the medical school curriculum is already so packed, but we have seen how public health is so important during the COVID-19 pandemic. Also, we really rely upon physicians and other medical professionals, nurses, nurse practitioners, physicians' assistants, and more, for educating the public. And educating the public against the misinformation and deliberate disinformation that has been put out on social media and throughout the airwaves. And so I think it is very hard for the public to understand that. They go to their provider and they ask, and if their provider doesn't have some grounding in that in medical school, then I think it makes it really difficult, medical school and training. I can tell you, I can't tell you how many times, both in academic medicine and in public health, that I think back and it's like, well, how do I know that? I was like, oh, I learned that at Tulane, or maybe I learned that during my residency program at Mount Sinai. It goes back 40 something years, but I was very well grounded. And when I was teaching medical students, seeing adolescents, in particular, I treated adolescents with eating disorders, much of it goes back to basic physiology and even basic biochemistry. And as I was teaching Penn State students, it was like, that's why you do those years, is because you have to go back to those to understand what's going on with your patient and understand how best to treat them. It's the same with public health.
Thank you very much. Before I go on to see if you had any concluding remarks, I wanted to point out that A couple of things. I know we have some people that aren't usually in this, and you've, I think, only been in the auditorium a short time now. We've changed some things. We've
Yeah.
taken down the portraits, but we put up some of the giants of Tulane Medical School.
Thank you.
So anyway,
When I came in, it's hard for me to wrap my head around.
yeah.
Because I've been in this room 40 years ago many times, including when on match day, if I remember. So many times, and so that is just a tremendous honor. I appreciate it. Thank you very
Well,
much.
you bring honor to us.
Thank you.
Thank you for being here.
Thank you.
We have a few minutes if there's any questions. A few minutes left.
Okay.
Sure. Questions from the audience? Hi. Of course. How you doing?
We live in Colorado, so we're a burn state, one that burns
Yes.
regularly and more recently. But we also open burn in our farming, and we live in a valley that fills with smoke. We have inversions, we have a lot of asthma, we have children and adults that suffer. Is there a new way, for 30 years we've been fighting this, to connect with farmers and our ranchers and our orchardists to be working in these kinds of farming communities and states, those alternative to burning the fields when we already have so much smoke from open
Right.
fires? And is there your department filtering that back through agriculture department?
So it wouldn't be as much my department, but that would be responsible for it. But again, we're that connective tissue. So to try to make those connections. So that's really interesting. We can talk about that later this weekend. You can certainly email me, and I can have our team talk to USDA, to the Department of Interior, and all the different departments that are involved in that. It might shock you. I was certainly surprised, but there is a certain bureaucracy to the federal government, and so. So we have to deal with that type of bureaucracy. Well, who knew? But that's what we're supposed to do, is to try to make those connections. But you're right. I mean, the forest fires are exacerbated by climate change, and they are worse than ever. And so there's obviously challenges in terms of the fires. Of course, if you have means, you can rebuild. And if you don't have means, then you've lost your home. And then also, though, the smoke, as you said, the resulting smoke, which impacts communities and worsens and exacerbates respiratory conditions. So we'll talk about it later, and we'll try to make some connections for you. Yeah.
Hi, thank you for being
Hi.
here. I'm new to it, and one of the questions I have, just coming back locally, do you know if our clinical partners hospital system has made the pledge? And if not, what can we do to actually?
My understanding is that the health system has not made a pledge. So it would be good to talk with people in the health system about looking at the issue, and I'd be glad to talk to them anytime. Now, we realize that different people are different health systems and hospitals and are in different places. And some, especially coming out of COVID and the challenges that hospitals and health systems have had with COVID, that not everybody can make the pledge at this time. I guess then what we ask is that you just look at the issue. Is look at the different components of the issue. How could you make the pledge in 3 years? Could you make the pledge in 5 years? Can you just work on the problem? Because the problem's not going to go away. It's just getting worse. And so we have to deal with it now. I think it's a moral imperative that we deal with it now. And so everything is positive. It's all carrots and no sticks right now. So and there's money in the Inflation Reduction Act, and we can help you find that money to be able to accomplish some of those things. In the back.
Hi, Dr. Levine.
Hi.
Thank you for coming to talk to us. I'm Carlos Vasilio. I graduated with an MD in patient planning with a focus in environmental health and disaster management. I'm a current medicine chief resident, and I attended the VA. So my question is more so advice, career advice-wise, that most of the advice I've been getting have been really siloed, either from the homeland security perspective or the medicine perspective on how to have a career in my interest in environmental health and medicine. So I don't know what so you mentioned the different initiatives of your office, different governments,
Yeah.
academic. So for people who are interested
No, I don't think it has to be separate at all. And I think they absolutely can be joined. Glad to talk with you later. Or, if you come up and see my special assistant, he can give you my card. And so we'd have to talk about your specific interests and things. But, careers ebb and flow and they change, right? So, I mean, when I left here, I wanted to do pediatrics and adolescent medicine. And I went to Mount Sinai in New York City, and that's exactly what I did. So I did pediatrics, then I did an adolescent medicine residency program. Then I did a bunch of different things. I was in academic medicine at Mount Sinai, but I also did some practice, and I was also at Lenox Hill. So I did a bunch of different things. And then I left from Manhattan, 80th and First in Manhattan, and moved to Central Pennsylvania and the Penn State College of Medicine. I still think, actually, that's the biggest transition I've ever made, which says something, actually. But then I went into academic medicine in a different way. I really concentrated on adolescent medicine. And, as you said, I was professor, I was division chief, I was vice chair. So what does a vice chair do in your career? Well, maybe you become a chair, maybe you become a dean or a vice dean or, an associate dean or something. But I had this opportunity to become the physician general of Pennsylvania, and I just jumped. People thought I was completely crazy. Like, what is the physician general of Pennsylvania and why are you doing that and leaving the academic medicine career that you spent your entire life building? And I just felt it was an opportunity to do that. And then I became the Secretary of Health, and now I'm here. So you never really know where your career is going to lead you. I guess one of the things is just to be open to it. But you do need to start someplace, and I understand that. So, I think there is absolutely a way to combine those type of interests. And I don't think you have to completely choose. And glad to talk to you about it. There aren't many times that you have somebody from the White House and from the HHS and administration sitting right there ready to answer any question that you might have. So I guess I'd take advantage. Yes.
This is sort of a connective tissue question for you. It turns out that a third of greenhouse gas emissions come from the human food systems.
Yes.
And so in terms of this, what contributes to that is our dietary carbon footprint.
Right.
And it turns out that the Secretary of Health and the Secretary of Agriculture every 5 years put out dietary guidelines for Americans.
Right.
And 2 cycles ago, 2015, there was an expert committee that informs those guidelines, had a whole chapter on sustainability, a whole discussion of these issues. And both Secretaries of Agriculture and Health X'd out that chapter. Never saw the light of day. And the issue of sustainability in dietary guidance, which seems like a basic thing we ought to inform the American public about, has not appeared. And so I wonder what initiatives Secretary of Health might take to include that information in the guidelines.
So the dietary guidelines for HHS comes out of my office. So the buck stops here. And the 2025 guidelines are coming directly out of our office. It changes every 5 years. So 2020 was USDA. 2025 is my Office of Disease Prevention Health Promotion. So as we are looking with the committee to put together those guidelines, we have asked the NIH to look at that issue. And so we've asked the NIH to study exactly the issue that you're talking about. What would be the relationship between the dietary guidelines and the food system that in terms of relation to impact on carbon emissions and climate change. So we're looking to study that problem. So we've asked the NIH to do that probably about a year or so ago. So I think it's an important issue. We don't know the answer yet, but we do think it's an important issue. It is not likely that there's going to be specific recommendations in these guidelines, maybe an addendum or something. So we've asked the NIH to look at it. Yeah.
I'm like just as tall standing and sitting. Hi, I'm Heidi Bro. I always say Heidi Bro from New York because I'm from New York and I moved from Park Slope, Brooklyn down to here. So.
Oh, the center of the universe, Park Slope, Brooklyn. That's it. Everything revolves around that.
And, I was working for the Department of Health before Tulane under Dr. Daskalakis. And,
Yes.
I'm a social worker, professor for 10 years, and a medical social worker over here at Tulane Hospital in the Veterans Program. And so I'm also a parent, and so I was just wondering, we do a lot of, I have like EDI consulting company, a lot of things at home. The kids are very interested in that type of stuff, but either like as a parent or as a teacher or as a social worker for us in the room that aren't physicians, what advice would you have maybe as good places to start or do more?
I think it is that there is a tremendous room for work on this issue from everybody. And I think that there's an opportunity for work in communities, in schools, in health systems and medical centers. I think that there's an opportunity to do this for families, right? Because your kids are the next generation. And so I think that I would educate them about the issues that we're talking about, age appropriate way, but I think it should be done in schools and it should be done in communities and really cities and throughout the country, because we're all in this together. I mean, there's one Earth, and these issues of climate change and the environment, they don't stop at borders. They don't know borders, and so throughout the entire world, we're seeing the same type of issues that we have now. In terms of specific resources, you can get our card for one, and I'd have to ask my staff about what resources would be appropriate, for example, for kids. I don't know that off the top of my head, but we can find those. We also have somewhat of a global footprint. So we go to COP, I was at COP 26. Our team went to COP 27. The goal is to go to COP 28 in the United Arab Emirates. And so we're working about this throughout the world. I mean, if you add all of the health systems of the entire world and the carbon footprint, it'd be about the 6th or 7th biggest country in terms of carbon emissions. So it's not just the United States, although the United States is the biggest player in this, but of course, the United Kingdom and Canada and throughout the EU, et cetera. So we do have those international discussions, and I hope to be in Dubai, which will be interesting.
Yeah.
You're a key part, we emailed a few times.
Yeah.
Is there any hope for kind of common sense legislation to get passed? For example, plastic bags. When you go to Europe, no one else is
Right.
using plastic bags. And to me, I just don't understand why we can't shut down that part of the economy.
Plastic pollution is significant, and it certainly plays a role in terms of harming our environment, especially single-use plastic. Think how much single-use plastic is in the hospital. Just think about when you take care of your patients. There's a video that someone made about they had an operation. I think it was actually in the EU, and they basically laid out all the plastic that was involved in their operation, and it wasn't an unusual operation, and it filled like a high school gym. So if you think about how much plastic, and then the plastics that we use, and I do the same in the water bottles and stuff, we really need to work on all that. So also the plastic is made from petrochemicals. I mean, really, the petrochemical industry is much more interested in plastic now than in just oil for cars, gas for cars. I mean, that's kind of passé, and they know that's probably going to go away eventually in terms of electric vehicles. If you're thinking long term, but that's where the future is for the petrochemical industry. And so there's a lot of pushback. Is there hope for legislation? There's always hope. Hope springs eternal. There is limit on plastics in other states. If you go to Vermont and Connecticut and other states, there are limits on plastics. I don't know about the politics of Louisiana that well, but I would bet you it'd be a challenge. And right now, in terms of national legislation, glad to go to Congress with you to testify about it. We'd have fun.
Yes.
I just can't resist the opportunity.
Sure.
To ask you this, but when I've heard you speak on long COVID, and I thank you for your efforts for the report that you put out, I've heard you start your talk saying long COVID is real.
Yes.
Which is so important for clinicians, for patients. I think it says so lives. The anti-science that
Yeah.
has us, when we talk about something like this, making that point first and foremost.
Right. Well, I think that patients have had, with long COVID, have had significant challenges, getting their, kind of getting the significance of their system, of their symptoms and the point across to the medical community. And I think, unfortunately, the medical community has sometimes looked upon the severe symptoms that they've had, sometimes disabling symptoms, with a skeptical eye. I think that there are many reasons for that. First, we are seeing significant skepticism in science, medicine, and public health right now. I think that that's been exacerbated by the COVID-19 pandemic, exacerbated by misinformation and actual disinformation on social media and in other mainstream media outlets. I also think that one of the biggest challenges that we have is that the COVID-19 was so politicized. When I was in Pennsylvania giving recommendations, there was nothing political about it. It was just public health. And it was pretty basic public health, and so that has been politicized. But also, skepticism in mind-body connection is not new in medicine. I mean, really, one of the things you mentioned, Dean, is one of my specific interests and why I went into adolescent medicine, and thought about that 40 years ago, influenced by Dr. Hyman Thomas, who was a physician here in this brand new field of adolescent medicine that sparked my interest on it. That mind-body connection, I think, is treated with skepticism by too many physicians. That your mind and body are connected. That you can have symptoms that are influenced by your nervous system, that can be exacerbated by mental health issues, but that are actually primarily physiological, neurological, et cetera. And so I think that we need, for example, looking at chronic fatigue syndrome, myalgic encephalitis, and the skepticism that those patients have had for many, many years. And so, there are some similarities between ME/CFS and certain aspects of long COVID. The NIH has seen that, and is, there are similarities about post-infectious illnesses in general, and long COVID. Long COVID has its own unique characteristics. So we need to work on educating in academic medicine and in all physicians about long COVID. So there are many different aspects of what we're pulling together. One is the research. And so the NIH has the Recover Project, and looking at the pathophysiology, looking at different syndromes that might be associated with long COVID. Long COVID might not be one thing. It might be several different things leading to a common pathway. So the NIH is working on all of that. We hope that their clinical trials will start this year in 2023, a number of different clinical trials that will start. There have been other clinical trials that have already started, so we'll see. The CDC's Inspire project, looking at the epidemiology of long COVID. And then we also work closely with the VA. The VA, with their integrated health system and integrated medical record, has had some fantastic research, including neurological research that came out in the last month. From Dr. Al-Ali in St. Louis, I believe. So some really interesting results. So we don't do the research, but we help pull that together. But in addition, we need services and supports for patients with long COVID. And so their ARC has $10 million to try to put together some hub and spokes models. And then HRSA has asked for significant money in the 24 budget to educate primary care providers about long COVID, so that patients get the care that they need. They can be referred to tertiary care medical centers when they need that, but a lot of it is taken care of by their primary care doctors. So we really need to look at all different aspects. And, in the 24 budget, there's money to do that. So hopefully it gets passed. But all these different issues, I think, are really, really important. But they also, I think, signify that we need to educate students and residents and providers better about mind-body connection issues. Yeah.
So thank you for speaking to us. We appreciate it. I'm a student here, and I just have a question. You talked a little bit about how these environmental health issues are very politicized. So how is your office kind of working to ensure that some of these efforts are continued when
Yeah.
Well, so one of the ways that we're doing that is, for example, working with the National Academy of Medicine. The National Academy of Medicine is not political in any way and involves, medical and other physicians and other medical professionals. And so one of the really interesting things we're doing is that collaborative, is the climate collaborative through the National Academy of Medicine. And we're trying to break down political barriers, break down political issues, and to talk about the issue with a completely non-political organization. Unfortunately, even though I don't really consider myself political, I'm a doctor. I'm a physician and public health professional, and I don't really. Politics doesn't really enter into my decisions about things, but because I'm a presidential appointee, it's politicized. So I think the work through the NAM is how to do that.
Yes?
So you mentioned 8.5%. The healthcare community contributes 8.5% of our carbon footprint.
Right.
So the U.S. economy is 25 trillion, healthcare is 4.5 trillion. About half of that comes from CMS. Is there any link in the future that you may connect provider participation to helping reduce that 8.5% target?
Through CMS?
Yes.
So CMS is very involved in everything that we're doing. So I talk with the administrator of CMS quarterly. We talk with the medical director of CMS monthly, and we include these type of issues. And so there are discussions about quality initiatives, for example, and how they might do that. The CMS has some very powerful regulatory levers. We're using carrots instead of sticks. So could stronger regulatory levers be done in the future? Maybe, but that's not our intent right now in any way. So again, there's money in the Inflation Reduction Act, and there might be quality initiatives and types of things like that. But we're not anticipating strict regulations that would punish hospitals and health systems at any time in the near future.
I'm not trying to put you in
Yeah.
that position.
That's it.
I'm just thinking
Yeah.
if that's where a lot of the money comes from.
That is where, and we absolutely realize that. So we have a lot of skin in the game. Yes, absolutely. One of the biggest issues is the supply chain, and the toughest nut to crack. I mean, it's not easy to make your hospital, and decarbonize your hospital, but supply chain is much worse. And so we're not asking for a pledge about doing the climate, the supply chain. We're asking for you to look at the supply chain. And eventually it will come down to incentives for the supply chain, both government incentives as well as private, incentives to decarbonize. And a lot of it's going to kind of come down to that, the health system chooses this supplier rather than that supplier because this one is working on it and that one's not. We're trying to work that. We're also networking with the National Health System in Great Britain because they're looking to do that too. Now, of course, they're completely centralized. And so they have a big lever. I mean, they have enormous lever because they can say, all of our contracts are going here instead of there. We don't have that, but with different system. But we are learning from them and they're learning a little bit from us. I think that's it.
I think so. I think you're able to join a
Sure.
short reception.
Absolutely.
And thank you.
Thank you so much.
Thank you.